Now, Dr. Ed Wolin, many of you know, um, he's actually an internationally known oncologist, and he is a specialist extraordinaire regarding neuroendocrine cancer. So we're going to bring him up. Patients travel from all over the country to see him, and we are fortunate enough that he used to be in California. It was kind of a long ride for us to get to him. Then he stopped in Kentucky, and that didn't work out for him. And we're fortunate enough to have him in the New York area. So please welcome Dr. Edward Wolin.
Well, it's a great pleasure to be here today and talk to you about a big passion in my life, the management of neuroendocrine tumors. There's so much that has happened in the last couple of years that have just revolutionized the treatment. And I just want to share some of the excitement with you and share with you some of the new developments in the field. The title is PRRT chemotherapy and a gallium scan, but I think you'll see there's several other things are happening as well. It's a very exciting time. I'm at Montefiore Einstein Medical Center in New York, where I run a neuroendocrine tumor program. First of all, before we talk about chemotherapy, I just want to give you a few basic principles with respect to these neuroendocrine tumors. First of all, chemotherapy, biologic therapy, and what we call peptide receptor radiotherapy usually cause only a minimal reduction in tumor size. However, they can markedly prolong the life of a person with cancer to the point that you can take what otherwise would be a fatal disease and turn it into a chronic illness where you could live long, happy life with the cancer kept under control. So that is a primary goal of treatment. Obviously, whenever cure is possible, that's a goal. Whenever it's possible to get rid of it, we always try to do that. But even if the cancer can be stopped in its tracks, and a cancer which you might have already had for 10 years can also be in your body for the next 10, 20, 30, 40 years more, you can still live with that metastatic cancer as a chronic illness. So this means thinking about it a little differently than the way most people think about cancer in general. Since most cancers, you either cure them or you die from them very fast. This is a different kind of a cancer. It's a very slow-growing cancer and one with a different type of treatment and different natural history. There are tumors that we're not going to be talking about too much today unless there are specific questions, and I'm happy to deal with questions about this in the question period. What are called high-grade or poorly differentiated tumors. These respond very well to chemotherapy, although the response is often not as long-lasting. Also, a basic principle is that when tumors begin in the pancreas, a pancreatic neuroendocrine tumor has a higher chance of responding to almost any type of chemotherapy or biologic therapy than cancers of the neuroendocrine type that start in other parts of the body. Okay, so we'll jump in. Targeted biologic therapies increase blood flow to the tumors, can make a nice target for therapy. You could have therapy directed at the blood vessels, starve the cancer out by not allowing them to have enough blood supply. They also, as a principle, have more tyrosine kinase growth factor receptors, so you can use that as a target for treating neuroendocrine cancers. You can target genes that make the cancers malignant and things that make the cancers metastasize. You can target things that make the cancers live for a long time so they die faster. And we'll talk about many drugs and treatments of all these different types. But these are just basic approaches to treating a neuroendocrine cancer. Okay. I wanted to emphasize the incredible amount that has happened just in the last few years, what I mentioned right in the beginning of my talk. When I started this field, we had really no drugs at all for treating neuroendocrine cancer. We started having one drug for pancreatic neuroendocrine tumors, streptozocin, in the 1980s. But then it wasn't until the 2009, 2011, we started having a few more drugs. And now there's just a rapid progression of new things that are happening, and it's very exciting. So we really have a lot of things to do, and now the choice is what to do when. rather than having nothing to do at all. And I feel very privileged to have been part of the development of most of these treatments that we now have as standard care. Molecular profiling is something you might have heard about in neuroendocrine cancer and in other cancers. This involves analyzing the genes of the cancer to try to predict what kinds of chemotherapy might work. There's very little information right now about neuroendocrine cancer, but we're hopeful. There was a study that was done by Dr. Richard Warner and others using molecular profiling in cancer patients. They had 41 patients that they went back and reviewed retrospectively, and they had 12 patients where they had good data for follow-up. And in 9 of these patients, they were able to identify a treatment based on these genomic features and the genes in the cancer to help predict what kind of chemotherapy to use. And 5 of these 9 people responded to treatments. And again, these were treatments they might not have otherwise received because they were predicted only by this genomic test. So just be aware that this is a modality that's in its infancy, but over the next several years, and maybe aided a little more with the big Moonshot on Cancer initiative from the federal government, we're going to be seeing more genomic information that will turn out to help personalize care. You have to realize also that at this point in time, there are a lot of potential pitfalls with molecular profiling, including using assays for molecular profiling that haven't been adequately validated. Selecting patients for a treatment maybe inappropriately. You may think there was a mutation based on an original biopsy, and there might have been a lot of other genomic changes that happened since the original biopsy was done. It increases the cost of care. You may identify only a rare mutation in many, many people that are screened, and targets continue to change as metastases develop and additional mutations happen. But with all of these shortcomings, I think we need to stay tuned. This is a very, very exciting field. And one of the very exciting things in it also is that it's now becoming possible to do what we call a liquid biopsy. Instead of biopsying the cancer, you can do a blood test and find evidence of cancer DNA and RNA and other genomic things in the blood. And you can tell from a blood test what is going on in the cancer and what kinds of treatments might work. Again, this is all early on, but I think that just in the next few years, it's going to really explode in its usefulness. Another type of therapy I wanted to touch on, which Dr. Gerstein also mentioned, is immune therapy. Immunotherapy drugs stimulate the patient's immune system to attack cancer cells or use infused antibodies to attack cancer cells. So using immunity rather than something outside the body. Specialized white blood cells called T cells can be stimulated to kill cancer cells by drugs that allow them to recognize and kill cancer. One of the things which we're working on right now is called immune checkpoint inhibitors. This is a tumor cell, and the thing in pink is an immune cell, a so-called T lymphocyte. This T lymphocyte is able to recognize the cancer cell and has the capability of making the cancer cell drop dead. However, there's an interaction here between PD-L1 on the tumor cell and PD-1 on the tumor cell. And as long as this interaction is happening, the cancer cell does not die. But by breaking this little interaction right here, as you can see, the T lymphocyte turns on, becomes a lethal attacking weapon, and destroys the cancer cell. So by working right here at this interaction, it's possible to kill cancer. And this has absolutely revolutionized the care of people with melanoma and lung cancer and many other kinds of cancer. And we're very, very excited about its potential in neuroendocrine cancers. In high-grade neuroendocrine cancers, there were 2 papers that were presented at the American Society of Clinical Oncology in June this year in high-grade tumors with incredible responses in people that were otherwise resistant to therapy. In one study of a drug called pembrolizumab, 35% of patients had a huge shrinkage of their cancer. Another study, a similar drug called nivolumab, was used in combination with Ipilimumab. It was a combination of two drugs that were stimulating the immune system by interfering with that interaction of PD-1 and PD-L1. And with the combination, a remarkable 54% of patients had a major shrinkage of their cancer, not just prolongation, but actually making cancers tremendously shrink. So we're very, very excited about this. And based on this principle now, we have a clinical trial in all types of neuroendocrine cancers, so-called well-differentiated neuroendocrine cancers, carcinoid tumors of every type, small intestine, large intestines, anywhere in the gastrointestinal tract, lungs, pancreas, thymus, all sites, to treat with an immune checkpoint inhibitor to apply this principle that's been established in high-grade neuroendocrine tumors in people that have grade 1 and grade 2 normal types of neuroendocrine tumors and carcinoids. So this is going to hopefully be active and up and running, accruing patients in just the next 2 or 3 months at Montefiore and a few other centers in the country. There's another principle called adaptive cell transfer that I think you'll probably be hearing about more this afternoon when we have an immunotherapy speaker. There are drugs called cytokines that stimulate the immune system, like interferon. They're actually active in neuroendocrine cancer, although they're used maybe a little bit less now than they used to be, but just be aware that they can work well. And this is one of the areas that I think we should all really stay tuned for. It's going to increase literally on a month-to-month and year-to-year basis in its applicability to neuroendocrine cancers. Okay, the next really important thing to talk about is what is called a somatostatin receptor and ways of attacking that target. First of all, what is somatostatin? This is a small protein, a peptide, which works as a turnoff in the endocrine system. It stops endocrine cells from growing. It stops endocrine cells from making hormones. It turns them off. And by doing that, you can turn off the growth of a neuroendocrine tumor. This is remarkable. And it's generally extremely well tolerated. The major side effect these drugs tend to have early on is that some people have what we call gastrointestinal side effects, which involve increased bowel movement frequency and lots of gas, which is due to an inhibition of producing pancreatic enzymes. And if that's recognized and treated with enzyme replacement, it usually that side effect can go away, and people can tolerate these drugs well and can tolerate them for many, many, many years with minimal problems in terms of long-term troubles. The reason we use somatostatin analogs is that the natural somatostatin, the kind that's normally found in your body as the normal turn-off hormone, lives only for 2 or 3 minutes before it gets destroyed. You eat a candy bar, your blood sugar goes up, you make insulin, your blood sugar comes down to where it should be, and then right away somatostatin comes along and stops the insulin from working, otherwise your blood sugar would go down to 0 and you'd be passed out. So you need to have a turn-off hormone. It just works for a short time. But to make a medication that has a long half-life, people make Octreotide, Lanreotide, these different so-called analogs of somatostatin. They work the same way, but they're extremely well tolerated and long-acting. And for both of these drugs, we have long-acting formulations that can be injected one time every 4 weeks. A study was done with Octreotide versus placebo. It was done in Germany, called PROMID. And this really established for the first time that there are major anti-cancer benefits from using a somatostatin analog. The people that had a placebo before the cancer grew, they averaged about 6 months. And when people had Octreotide LAR, a somatostatin analog, it controlled the cancer for an average of 15.5 months before the cancer started growing. So that's called a PROMID study. However, it was a small study, and it did not lead to accepting of that treatment as a standard in the United States, although it clearly works. The study that has made the biggest impact in the United States is an international trial known as Clarinet. You can see from the title how you can make that title say clarinet. It's really kind of a stretch. But in any case, this is a randomized trial of Lanreotide, which is this somatostatin analog I was just showing you before. It's somatostatin analog, which is subcutaneous. So instead of having a deep intramuscular injection with a long needle, it's done with a small injection under the skin, a subcutaneous injection once every 4 weeks. And in the people who got lanreotide, cancer control was remarkable. The average time that happened before cancer progressed, at the time the study was finished and published, the average hadn't even been reached yet. Although with subsequent follow-up, it looks like an average of 33 months. But I have people who have been on lanreotide for 5 years, 10 years, and more who have never had any cancer progression. It just stops the cancer from growing. It's a remarkable drug with very few side effects in most people. The people that had the placebo, it was roughly half of what it was in the people who got lanreotide. So this led to rapid approval by the FDA, and we now have it as an approved drug in the United States for neuroendocrine tumors of lung and, for neuroendocrine tumors of the gastrointestinal tract and pancreas. Lung was not included in this trial, but gastrointestinal tract and pancreas. Another trial was done with lanreotide looking at control of carcinoid syndrome. How well did it stop diarrhea and flushing? It turns out it actually can do that quite effectively. And you can see that in this randomized trial, the people that had lanreotide had less diarrhea. That was a complicated trial design based on using fewer octreotide rescue shots. The patient reported control of diarrhea during lanreotide. You can see most patients were very happy with the result. As I mentioned, it was not available for lung carcinoid. So we now have a trial which is up and running. We have it at Montefiore, lanreotide in lung carcinoids known as SPNET. Again, a little working with the title to make it spell the right word. But this is a trial of lanreotide for lung carcinoids. And I think that anybody who has a lung carcinoid who has not received any kind of somatostatin analog can potentially benefit from this. And lanreotide is provided for free, and it will hopefully establish an important role for lanreotide in lung carcinoids as well. There's another analog I just wanted to mention very briefly that I'm really excited about called Pasireotide. It's a somatostatin analog that has much more sticking to neuroendocrine cells. Instead of sticking to primarily one type of receptor, it sticks to 4 out of the 5 types of receptors. And compared to octreotide, it looked like there was an additional 5-month benefit in control of cancer. So we await more studies. The next thing I wanted to talk about is the somatostatin receptor on the surface of the cancer cell is not only a target for somatostatin analogs like octreotide and lanreotide, but you can also think of it as a place where octreotide or lanreotide could stick, and you could attach something to the octreotide to deliver a radioactive isotope. This is allowing enormous advances in both diagnosis and therapy. What this is showing you over here is a complicated molecule that consists of octreotide right here, something like octreotide with the area that sticks to the octreotide receptor in blue. So this sticks very tightly and very specifically to octreotide, to somatostatin receptors. You then attach to it through a little linker a radioactive isotope. In this case, it's lutetium-177 that shoots out a ray that only travels about a 1/16 of an inch. It can nuke all the cancers in the body simultaneously with very, very little collateral damage by an intravenous injection. Very, very powerful therapy that we call now PRRT, peptide receptor radiotherapy. And this is turning out to be probably the most effective kind of treatment for metastatic neuroendocrine tumors that has ever come along. Okay, PRRT. You can also use a different isotope right here called gallium-68. And when you do that, you could use exactly the same molecule with this tracer isotope to shoot out a scanning ray. And by doing that, you can get an unbelievably powerful diagnostic picture of where the neuroendocrine cells are in the body and prove the affinity of the binding to the receptors. I'm going to show you examples of this soon, and you'll realize the power of these techniques. So this is another picture of exactly the same concept. You have a target, which is a neuroendocrine cell. You have a ligand that sticks to the target, which is octreotide or a slight variant of octreotide, and it's linked through this chelator thing to a reporting unit to make a scan, which is gallium-68, or a therapy unit for destroying the cancer, which is lutetium-177, for example. And as soon as that is injected IV, the lock fits into the key, it activates the somatostatin receptor, and then everything starts happening that we talk about. The definitive randomized trial that will hopefully lead to an FDA approval of peptide receptor radiotherapy next year is what we all hope and pray will happen. Right now, it's still investigational. We have it available for people who need it at Montefiore Einstein in New York. And it's using exactly the same drug as the active drug in the NETR1, the lutetium-177 dotatate, which goes by a brand name of Lutathera. Okay, so the way this works then is that patients who are being treated get 4 intravenous injections. They get an injection of lutetium-177 dotatate IV every 8 weeks for a total of 4 times. So it happens over a period of 4 months. You come, get an outpatient treatment, and go home. 2 months later, you do it again. 2 months later, you do it again. 2 months later, you do it again, and you're all done. Just with those 4 treatments, the average period of cancer control lasts and lasts and lasts. This is amazing. The way NETR1 was designed, this particular trial, was there was no placebo. The people that did not get the radioactive octreotide got a double dose of regular octreotide. They got 60 milligrams every 4 weeks. So the people that progressed on 30 milligrams, double the dose. You give them 60. The average time that a controlled cancer was 8 months. If you gave the radioactive octreotide 4 injections, so-called PRRT, those people, the majority, are still doing fine with no recurrence years later. We don't even know how long the average is, but if you kind of extrapolate the curve, it looks like an average might be 40 months. And we know from previous experience in Europe that the average in their experience is about 40 months, and that's half of the people. Half of the people, it's better than that. And you may go for 5 years or 10 years, or who knows, before the cancer ever grows. The average is 40 months. And this is way, way better than any other treatment that we have for metastatic carcinoids. So I think that it's just really good to know that this is available. And it's appropriate for people who have somatostatin receptors on their cancer. If you have negative imaging and don't, with a somatostatin analog, for example, and you have a negative Octreoscan or a negative gallium-68 PET scan, this treatment wouldn't work. But fortunately, maybe 80% of the time, those scans are positive. You do have receptors, and the treatment will work, so, or has a good chance of working. It looks like people who get the radioactive octreotide also have a better survival, although the data is still early. But the people who got the radioactive octreotide, since the study was started, there were 13 deaths, and then the people who did not get the radioactive form, there were 22. So we have to wait longer follow-up, but it looks like even in survival, it's making people live longer and better. So the conclusions are obvious that this is a good treatment. On the basis of that, we have what we call an expanded access trial of lutetium-177 dotatate. This is the trial I referred to earlier, which we're doing right now. And this is for people who have metastatic disease, people where you have an early disease that's a tiny tumor that can be taken out surgically. You don't need this treatment. But people who have such a disease, people whose cancer has grown after they've gotten octreotide or lanreotide, a progressive disease, people who have a positive scan and have any type of what we call mid-gut neuroendocrine tumor, ones that started in the intestines, appendix, cecum, part of the colon. these kinds of tumors are eligible for the current trial of PRRT. We're hoping that in the next few months, we will have access to PRRT for any kind of neuroendocrine cancer, no matter where it starts, because it does look like if you have a strongly positive scan, you still can potentially benefit from PRRT. And right now, it's more difficult to get in the United States for those other sites. This is a picture of showing you some of the nice things that are possible with gallium-68 and with lutetium-177. This is a patient who has metastatic cancer in the liver. This is a liver over here. The gray thing is liver. The dark thing is tumor. You see there's a tumor there. CAT scan, you can't see it so clearly, and you underestimate how much there is. When you do a gallium scan, they're intense, these black things, and you superimpose the two and make it look white instead of black, and these are cancers. And you can see the neuroendocrine cancers light up like light bulbs. This particular patient was treated with PRRT with lutetium-177. After one cycle of treatment, you couldn't even see on the CAT scan anymore, but on the gallium-68, you can see there's still cancer there. It's starting to get smaller. And after another cycle of PRRT, it completely disappeared. This particular patient stopped after 2 cycles instead of going for the full 4, and a year later it came back. But you wouldn't have known it came back from a CAT scan. You know it came back from doing the gallium scan and seeing those pictures. Okay? So if you've ever seen an Octreotide scan, which looks like taking ink and throwing it on a wall and trying to imagine where the tumors are, this is just an enormous, enormous improvement in sensitivity. In fact, this shows you the added value of a gallium-68 scan compared to an Octreotide scan. This is the same patient at the same time having an Octreotide scan. And the kidneys are black, the liver is black, the spleen is black, tumors are black, bladder is black, and it's so hard to tell what's tumor and what's normal liver. And it's all blurry. Then you do an Octreotide scan, and you can see much better. These pictures aren't even nearly as good as looking at the actual films, where you can just see the pictures light up so nicely, like in the ones I just showed you before. We did a study when I was in California before I came out here. In addition to being at Cedars-Sinai, I was also at UCLA. And in conjunction with the nuclear medicine department, we did a gallium-68 PET scan on 100 consecutive patients. Before the scan, we said, what will we do for therapy before the scan? And then after we saw the results, we say, now what would you do for therapy? It changed therapy in a major way in 60% of patients. That was huge. People that were about to have a liver transplant had it canceled because they had 5 bone metastases. People that thought they were going to have 1 little tumor taken out turned out to have 20 tumors and instead went and had treatment to the whole body. People who thought they had metastatic cancer didn't and went ahead and changed their plans and had surgery instead because the other little dots were unrelated and not cancerous. It's an amazing test. And I think that once it becomes more generally available, hopefully over the course of the next year, it'll be replacing the Octreotide scan. Right now, we have it available, and we're doing it all the time at Montefiore, but it's going to be much more accessible now that a new billing code has been created to allow insurers to pay for it next year. Right now, it's more complicated, but it is FDA approved, and it's going to be widely used. Now, next thing, switch gears a little bit after the somatostatin analogs, is I want to talk about a new class of drugs called mTOR inhibitors. This is a picture of some giant stone heads that are sitting on the grass of Easter Islands in Polynesia, the big island called Rapa Nui. People travel around the world to Rapa Nui to see these heads that probably weigh 100 tons and 100 feet high, been there for hundreds and hundreds of years, and nobody knows how they got there and what they're doing and whatever. It's like one of the wonders of the world. And this is an island that's completely uninhabited and so far from civilization that you wonder how anybody got there in the first place. Okay? So some enterprising young fellow went to the Easter Islands and was looking at the heads and got this brilliant idea that if he took back some dirt in a bag, he'd strike gold or something. So he brought this dirt back and he studied it to see if he could find a fungus that had never been discovered before, since it's such an isolated ecosystem and such an isolated environment. Maybe a fungus was growing in the dirt that wasn't anywhere else. And maybe this fungus was making an antibiotic, like streptomycin comes from Streptomyces. He'd find a new antibiotic and he'd be happy. So sure enough, he found a fungus that nobody ever found before, not in China, America, Brazilian rainforest, Africa, nothing. But it was in Easter Islands. So he called it rapamycin. He named it after the Rapa Nui Island. And that's how we got rapamycin. Well, it was a class of an antibiotic nobody ever found before, and nobody knew what it did. But it turned out that it not only killed microorganisms, but it also was able to stop certain cancers. And it worked on an enzyme that had never been found before. So to sound really scientific, they gave the enzyme a name. They called the enzyme mTOR. mTOR means mammalian target of rapamycin. See, it sounds really scientific, right? You have a drug, and what does it do? It's an mTOR inhibitor, naturally, because what does it do? It inhibits mTOR. But meanwhile, you don't have any idea what mTOR is and what's happening. So it worked so well that it stimulated generations of scientists and graduate students and everybody who had a laboratory to figure out what was going on. And it turns out this is a crucial regulator inside cells that determine how long a cell lives, how much food and oxygen it eats, and how fast it grows. And it turns out that neuroendocrine cancers have mutations in mTOR and the mTOR signaling pathway that makes tremendous amounts of extra mTOR and makes that drive the cancer to grow fast. And by inhibiting mTOR, you can stop the cancer in its tracks. It's not chemotherapy, it's a biologic drug, an mTOR inhibitor. So the first drug that was made was the drug that was just taken out of the microorganisms called rapamycin. Rapamycin has a generic name, just like everything does, as well as a brand. So rapamycin is also called sirolimus. That's the thing that comes out of there. So the Novartis company made a slight variation on sirolimus, and they called it Everolimus. It's a user-friendly pill. You can take it every day. If you get the dose right, it's usually well tolerated, although it can have side effects. And if the dose is too much, you can have a lot more side effects. But if you get it right, you can be on it for years and years and years. And it's very effective in treating neuroendocrine cancer. So that's how mTOR inhibitors came around, and that's why we do these clinical trials with Everolimus. The first major trial I wanted to talk to you about is called Radiant-3 in pancreatic neuroendocrine cancer. This was done at a time there was no treatment at all for pancreatic neuroendocrine cancers other than that one ancient chemotherapy. So it was felt to be ethical to do a placebo-controlled randomized trial, and it was called Radiant-3. Half of the people got Everolimus, and half the people did not get Everolimus. The people that got Everolimus had an average time of cancer control of 11 months compared to 4.6 months when people didn't get it. It tremendously improved cancer control. And remember, these are averages. There are plenty of patients more than 5 years later who are still taking Everolimus, but the average is 11 months. This is averaging people who have no benefit at all with people who can have cancer control for years. Okay, that's what they mean by average in a population. So this was approved as a treatment for pancreatic neuroendocrine cancer based on this trial that we did. And even though the primary goal was to just stop the cancer from growing, most patients actually had a shrinkage of their cancer. If you look at the blue, everything blue is smaller cancer than you started with. 0 is what you started with. And this is the percent of shrink. So a few people had a dramatic shrink. Most people had some degree of shrink. And there was only maybe 20% that did not have a shrinkage. In the people that got the placebo, they were also allowed to get Octreotide. And there were a few people that had a shrinkage, and that was probably the Everolimus, the people that got Octreotide. But you could see almost everybody progressed. Instead of 80% responding, you had 80% progressing. Okay? So another trial was done in neuroendocrine cancers of the intestinal tract and lung, known as Radiant-4 with Everolimus, recently completed, and again, proving to be very effective. The progression of cancer was prolonged from 3.9 months, again roughly 4 months, to 11 months. So it seems to be working as well in neuroendocrine tumors coming from the intestinal tract and lung as it does from neuroendocrine tumors of the pancreas. It works in all of these neuroendocrine tumors. It's a very, very good drug when people need it. The period of cancer control is clearly less than the statistical average with PRRT, but there's a time and a place for all of these, and the more things we have in our armamentarium, the more we can do to help patients live a long and quality life. There are new generations of mTOR inhibitors that we're working on right now. There was one called CC223. I treated 40 patients, and some of them are still on after years. It's been able to stop carcinoid syndrome symptoms and control cancer for a long time. And we have other studies that are being started with what we call dual kinase inhibitors, inhibiting the so-called mTORC1, which is what Everolimus does, and another enzyme called mTORC2 to overcome resistance. Now, what is this picture? Either very beautiful or very ugly, depending on your perspective. This is a cancer with its blood supply. Remember I said that neuroendocrine tumors have growth factor receptors, and they have growth factors that stimulate blood vessels to grow in the vicinity of the tumor. And the tumor has a blood supply which is different than the blood supply of the rest of the body. But it's enormous amount of twisty-turny little vessels. It's almost like the blood vessels inside a placenta. It's not like blood vessels that you just see in normal tissues of the body. And lots and lots and lots of blood vessels, which is why surgeons who operate on neuroendocrine tumors have to be sure that they don't make things bleed too much. You have to know what you're doing because they are highly vascular. They have a lot of blood flow and specialized blood vessels. So we can attack those special blood vessels with anti-angiogenic drugs. Anti-angiogenic drugs work specifically on attacking blood vessels. There's one called Bevacizumab, which goes by a brand of Avastin. It's been tried in NET, in neuroendocrine tumors. This is a monoclonal antibody. It's an immune therapy, but it isn't working by stimulating the body's immune system. It's working by attacking the growth of these new blood vessels. 24% of patients with carcinoid tumors responded in an early trial. A big trial was done, several trials using this drug in combination with a 5-FU or an oral form called capecitabine and another drug, temozolomide. Okay, and with this combination, people can respond well. There's another trial that was done with bevacizumab, which is Avastin compared with interferon. They're both really good, but the people that got the Avastin, the bevacizumab, had a bigger response. We don't know quite what the role of this is in therapy. It is not ready for prime time, but just be aware that anti-angiogenic drugs, drugs that affect the blood vessels, are active in neuroendocrine tumors, and if we can figure out a way to use them safely, it's going to be important. We also have some pills that have anti-angiogenic effects, and in pancreatic neuroendocrine tumors, the most important one right now is called sunitinib or Sutent, which blocks the growth of these new blood vessels, and it's roughly as effective as Everolimus. The average time to progression was 11 months versus 5.5 months in placebo in a randomized control, and on the same day that Everolimus was approved, sunitinib was approved also. So we have both of these drugs, and which one to be used first, it depends on the particular patient and discussion with the oncologist and the potential toxicity profile, but they're both highly active drugs. But we'll get to questions a little bit later. Yeah. Another drug, which is a pill that has anti-angiogenic effects, looks like it's quite active in carcinoid tumors, is called pazopanib. We just finished a randomized trial of pazopanib versus placebo in people with resistant neuroendocrine tumors, carcinoids. The results have not been reached yet, but if this turns out to be an active drug, which I'm hoping it will, we will then have a pill of an anti-angiogenic for carcinoids, namely pazopanib, like we do right now for pancreatic neuroendocrine tumors, with sunitinib. Now, cytotoxic chemotherapy is like what people refer to as chemotherapy, regular chemotherapy, if you like. Regular chemotherapy does not work very well in general in neuroendocrine cancer. It's not usually used, but there are a few kinds of chemotherapy which actually are good and which are effective. Streptozocin, which is an old drug. Did you want to say something? No, okay. So streptozocin is an old drug which still has activity. We use it less than we did 30 years ago because it does have potential of hurting the kidneys, which can interfere with other kinds of treatment. But the combination of streptozocin, doxorubicin, and 5-FU shrunk cancers by an average of 39%, which is really quite an excellent response rate. And nowadays, we're using more of a combination called temozolomide or Temodor with capecitabine or Xeloda. And if you use the two together, people sometimes refer to it as Cape-10, using those two drugs together. It also looks like it's highly active. A large randomized trial has just been done comparing temozolomide alone versus the Cape-10 combination. We don't know which one is better. That study has been finished. I've seen fantastic responses in both groups, so I can't tell you if the capecitabine adds to the combination or not, but the results will hopefully be available in the next year or so, and then we'll know whether temozolomide should be used alone or in combination. But I can tell you it's an extremely active combination, and they're pills, they're well tolerated by most people, and would be my first choice rather than that much, much more toxic combination of doxorubicin and streptozocin, which has a risk of hurting the kidneys, losing hair, lowering blood counts, and a lot of other things that are associated with chemotherapy. Okay, another thing that I want to talk to you about, which is an important new development that was alluded to by Dr. Gerson earlier on, is a drug called Telotristat. Now, I'm not trying to intimidate you by the slide with all the biochemical pathways. The important thing is that serotonin is made in carcinoid cells out of an essential amino acid that you eat in your diet called tryptophan. Tryptophan's in every protein you eat. It's an essential amino acid. You can't live without it. And your body also makes niacin out of it. In fact, if you get deficient in niacin made from tryptophan, you get a disease called pellagra. This is an important thing to have in your body. But when the neuroendocrine cells get a hold of it, the carcinoid cells, they turn it into tryptophan. And the way they turn it into tryptophan is by converting it into 5-hydroxytryptophan and then 5-hydroxytryptamine, which is a synonym for serotonin. If you block this enzyme, no more serotonin can get made. Okay? So this is the key, what we call rate-limiting step. This enzyme, tryptophan hydroxylase, and this drug, telotristat, stops it in its tracks. So your serotonin level will come crashing down, and diarrhea will get dramatically better. It's a pill. It has very, very few side effects. And most importantly, it does not get through what we call the blood-brain barrier. So it does not lower serotonin level in the brain, because if you lower serotonin in the brain, you get all depressed. And that's not going to be a good thing to do. But it doesn't seem to have an effect on mood. Okay? So this is a very exciting drug. It's completed this randomized phase 3 trial is already finished, where people were randomized to placebo or 2 doses, and then everybody got the active drug, no matter which group they were on. They got the active drug in full dose. The results were amazing. Bowel movement frequency dropped by 35%, in addition to whatever was possible with maximum doses of Octreotide. And the responses lasted for a very long time. 5-HIAA excretion in the urine went down by 58%, which is huge. And we're actually hopeful that in the future we can demonstrate a benefit in preventing carcinoid heart disease, which is one of the complications that can happen from too much serotonin. Now, I want to remind you that even though I've been talking about all kinds of exciting new things, the most important thing to remember is that what we have learned from the lessons of the ancient world actually has all we need to know to cure neuroendocrine cancer. This is an elephant, and these are 10 blind men who are feeling the elephant in different places. And these are all wise men who are trying to figure out what is an elephant. So one was feeling the tail, and one was feeling the trunk, and one was feeling the side, and each one thought it was a different part of the body. And so these men of Hindustan disputed loud and long, each in his own opinion, exceeding stiff and strong. Although each was partly in the right, all were in the wrong. Until they sat down at a table and talked to each other, nobody knew what the heck an elephant really was. And the one who thought it was a hose squirting water eventually was able to come to understand that that was only the trunk of the elephant. But they had to sit and talk to each other. Okay? So nowadays, we have a multidisciplinary team, as Dr. Gertzen was talking about, except instead of the elephant in the room, we have a zebra in the room. A neuroendocrine cancer patient is now the focus. And instead of 10 blind men, we have 10 blind doctors, each one blind to other specialties other than his own, to a very big degree. But if you get a medical oncologist, endocrinologist, radiation oncologist, surgical oncologist, and all these different specialties, all talking to each other in a multidisciplinary team, and you have experts together, that's how to make important therapeutic decisions. Should somebody have embolization of the liver? Should somebody have metastases resected? Should somebody have PRRT first and have those kind of treatments later? Should somebody have Everolimus first or PRRT first? What do we recommend to the patient? Okay, I have my feelings, but there may be some peculiar technical factor that makes surgery either a chip shot or so difficult that you would never even want to think about it. But if you don't have a surgeon putting in his input, you would never know, because there's really no medical oncologist who knows as much about cancer surgery as a cancer surgeon. So we have to talk to each other. And I couldn't agree more with everything that was said in the previous talk about the importance of multidisciplinary management. So on that note, I'd just like to stop now. It's a great pleasure again to speak with you. I want to thank Bob and Marianne Waman and NCAN for allowing me to come here and to meet with all of you today. I'm sure you'll have questions, and we'll get to those a little bit later. Thank you.